Endocrine pathology, syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH. All right, so for SIADH, this is just characterized by an excess production of antidiuretic hormone, also known as ADH or vasopressin. Okay, and so if we have an excess of ADH, all that will relate to is going to be an excess of free water retention, right? So we're going to have increase in alkaporins, and that's going to lead to an increase in water reabsorption at the kidneys. Okay. Now, there's three key findings that you have to be aware of that they love to ask about, and this is the highest yield thing. If you see hyponatremia, normal volume status, which is known as euvolemia, and concentrated urine, then the patient most likely has SIADH. Those are the three key findings, okay? Now, hyponatremia is secondary to the fact that we're essentially diluting our blood because we're retaining all of the water. However, even though we're retaining all the water, we have a normal volume status, okay? And that's very, very important to know. Lastly, you're going to see concentrated urine as a third key finding because, once again, you're taking all the water out of the urine and you're placing it into the serum, into the blood. And so that leads to a concentrated urine. So those three key findings are very, very important. They love to ask about it. And now what you have to know and what they love to ask about is treatment is for you fluid restrict these patients, okay? It's a first-line treatment. Don't allow them to drink water for a while. And then you'll be able to, that's your treatment of SIADH. And then lastly, there's causes of SIADH, okay? And they like to ask about the causes as well. So if you have any type of head trauma or CNS disorders, that can lead to overproduction of ADH. And remember, ADH is going to be produced in the hypothalamus and released from the posterior pituitary. So keep that in mind. Secondly, ectopic ADH can be coming from cancers, like small cell lung cancer is a very big one, which we already discussed within the respiratory system. If patients are taking any type of drugs, that can lead to SIADH as well. But keep in mind, head trauma and ectopic ADH secondary to any malignancy can cause SIADH. And the three key findings are hyponatremia, normal volume status, which is called euvolemia, and then they'll have concentrated urine. All right? Now, next is primary polydipsia and diabetes insipidus. We already discussed diabetes insipidus a little bit, but we need to go further in depth. First thing you need to know about diabetes insipidus is that it is either a problem at the brain, so known as central diabetes insipidus, or a problem with the kidneys, known as nephrogenic diabetes insipidus. And all that it is effectively unable to respond to ADH or a lack of production of ADH. So central diabetes insipidus has a lack of production of ADH. So you have an overall decrease in ADH release from the posterior pituitary. And so the patients, obviously, because they have a decrease in ADH release, they're going to have an overall increase in serum osmolality because we don't have water being reabsorbed at the kidneys. Once again, the ADH levels in the blood are going to be decreased, and that's very key to differentiating it from nephrogenic diabetes insipidus. Lastly, a question that they love to ask is treatment. If a patient receives desmopressin and they respond, okay, the patient actually responds and their levels begin to be normalized, then the patient has central diabetes insipidus, okay? So it was just a problem with producing ADH. So if we give the patient desmopressin, which is essentially an ADH analog, and everything fixes, then it was central diabetes insipidus, okay? Very important. With nephrogenic diabetes insipidus, we have ADH resistance at the kidneys, at the nephron, okay? And that leads to a overall, once again, increase in serum osmolality because we can't reabsorb water, but our ADH levels in the blood are going to be either normal or increased. And that's a key difference between central DI and nephrogenic DI. Central DI has a decrease in overall ADH, but nephrogenic DI has either normal or increased levels of nephrogenic DI, or have overall increased levels of ADH. Okay, and the reason behind that is because we're able to produce ADH, but our body's not responding properly to it. Okay, and when we give a patient desmopressin, the patient doesn't respond, which makes sense because, once again, it's not a problem of producing ADH, it's a problem with responding. So if we give them an ADH analog like desmopressin, it doesn't matter. It still can't bind its receptors and act. Okay, so the way that we treat nephrogenic DI is going to be with either hydrochlorothiazide or with water replacement therapy. Okay, now, within central diabetes insipidus, it can be usually caused to damage to the posterior pituitary or caused by damage to the hypothalamic nuclei. And what they want you to know is that if you damage your hypothalamic nuclei, then it's going to be essentially central diabetes that lasts forever. You cannot cure it. There's nothing that you can do. However, if you damage the neurons that release it from the posterior pituitary, then it'll just become transient central DI, meaning that it only lasts for a small period of time, and then you'll be able to come back to produce ADH. Okay, so keep that in the back of your mind. If you have hypothalamic nuclei that are damaged, you're going to need replacement therapy with desmopressin for the rest of your life because you can no longer produce ADH. However, if you damage the posterior pituitary nuclei, you're fine. It's transient. You only get a little bit of desmopressin treatment for that small period of time, and then you're fine later on. Lastly, if you see for nephrogenic diabetes, they love for you to ask about the cause, or they love to ask about the causes, specifically lithium. Lithium antagonizes the ADH's action at the kidneys. And so overall, lithium is one major cause of nephrogenic diabetes insipidus, especially when patients are taking it for bipolar disorder. So keep that in the back of your mind. They can talk about it in psych, or they can talk about it in nephrology, as well as endocrine. So once again, if I'm taking lithium, it can be a cause of nephrogenic diabetes insipidus. Lastly, hypercalcemia can also lead to nephrogenic diabetes insipidus because it leads to downregulation of aquaporins. With an increase in calcium, leads to an overall decrease in aquaporin production. All right. So overall, that's what you need to know about the diabetes insipidus. The last thing that they might ask you on is primary polydipsia, and it can be confusing, and you might get it confused with the diabetes insipidus, but I'll help you out. All primary polydipsia is that if a patient's just drinking too much water. Okay. So all these patients are going to be presenting with excess urination because they can't use their ADH, depending on what the problem is. If it's diabetes insipidus, they don't have ADH to, bring in, reabsorb the water, so they're just urinating it out. So they have constant urination, increased frequency of urination. In primary polydipsia, they're drinking too much water, and that's what's causing the increase in urination. So what they do for these patients that are drinking too much water to differentiate it from diabetes insipidus is that they'll do a water restriction test. So if I tell a patient to stop drinking water, then I measure their urine osmolality after it. Well, if they have primary polydipsia, if the issue is just them drinking too much water, then there's going to be a significant increase in their urine osmolality after water restriction. Okay? Because the only reason that their urine was dilute in the first place is because they were drinking too much water. There's nothing wrong anatomically that's causing the dilute urine. So if I restrict their water intake, they're going to have a normal response, which leads to an increase in urine osmolality. Okay? But for central diabetes insipidus as well as nephrogenic diabetes insipidus, it doesn't matter how much you have water restriction or not, you're not going to have a change. There's going to be no change at all within the osmolality of the urine. It makes sense because the problem is an anatomical issue. It's not due to the fact that I'm diluting my urine through drinking water. Okay, so overall, understand that difference between primary polydipsia as well as diabetes insipidus, but they like to specifically ask questions on diabetes insipidus and help you differentiate between central and nephrogenic diabetes insipidus. They ask more questions on the causes of nephrogenic diabetes insipidus, so be keen to the lithium as well as the hypercalcemia, but remember to differentiate them between the ADH levels in the serum as well as the treatment options. Desmopressin treats central DI, whereas nephrogenic DI cannot be treated with desmopressin. You would most likely give the patient hydrochlorothiazide.